Okay, this is the agenda we have issued. Having this meeting, very famous speakers, Professor Mario Plebani, of course he will speak, and then Dr. Sadit Kader and Dr. Tim Yi. Let me explain to you or introduce for a few minutes something about glycated hemoglobin.
Okay, as everybody knows, because these are very basics, hemoglobin A1c or glycated hemoglobin permits to monitor the exposure to circulating glycemia in the previous 3 months. Of course, for persons like me, that I am in the laboratory medicine and hematology for a long time, we all remember that the day before the consultation, the patients have diet, but you don't know exactly what was happening in the last times, the last month or the last weeks. And that was really difficult to manage the patient because you don't understand how they are so good, but they have a lot of complications. And because that, hemoglobin A1c has been used clinically since the 1980s as a glycemic control of the individuals with diabetes or prediabetes. The diabetes control and complications trial, that was very important milestone, demonstrated the benefit of the glycosylated hemoglobin because combining it with the glucose levels permits to avoid complications from diabetes. In 2009 was another milestone that the International Federation of Clinical Chemistry introduced a more precise measurement of hemoglobin A1c that gained international acceptance. Again, for me, I am not an expert as the professors and doctors here, but in 2018, it was a very big milestone because it was possible to measure in 2,166 laboratories, and here the speakers, Professor Plebani was part of this initiative, were able to see how many of the labs really fit with the gold standards of the measurement. They found that 1 in 20 not, but the 19 on 20, and that was a quality control, how the different laboratories and the different results can be used because the patients sometimes go from one lab to another lab, and that was another big milestone for the quality control of this glycosylated hemoglobin. And finally, yes, comment that will be discussed in depth for this by the speakers, that has been developed new methods as an enzymatic hemoglobin A1c to decrease the interference of or spurious results of hemoglobin A1c. That is one of the important topics of this conference. And with that, I will give the floor to Professor Mario Plebani, that is full professor of clinical chemistry and clinical molecular biology at the University of Padova, as director of the Department of Integrated Diagnosis in the University of Padova, director of postgraduate School of Clinical Pathology, editor-in-chief of Clinical Chemistry and Laboratory Medicine, and editor-in-chief of Gagnosis. Welcome, Professor Plebani. Benvenuto, Professor Plebani. It's un piacere. It's a pleasure for me to give you the floor.
Okay, thank you so much, Ramon, for this kind introduction. I like to thank Mindray for kindly inviting me to deliver this lecture, and I like to give my regards to all delegates attending this webinar. So I'm starting introducing the title of this lecture, that is Glycated Hemoglobin, the story of a successful biomarker. So what I like to do today is to share with you some idea about the story of glycated hemoglobin from the discovery to the current dominant role in clinical practice. I like to discuss something about the biochemistry of glycated protein, the clinical value of glycated hemoglobin assay, starting from monitoring but to the current value in the diagnosis, the issue of standardization, some criteria for diabetes diagnosis and the role of glycated hemoglobin, and finally some take-home messages. So this first slide is about the story, and we can really say that glycated hemoglobin is one of the most powerful biomarkers discovered and implemented in clinical practice during the last 5 decades. And I will say you that there are at least 4 eras of the story of glycated hemoglobin. The times of pioneers, starting from the 50s to the 70s, in which the heterogeneity of human hemoglobin was demonstrated using some chromatographic assay. The confirmation and identity between hemoglobin fraction and the separation of minor hemoglobin peaks, as you can see in this slide. So the so-called fast hemoglobin was firstly identified, and nobody known at the time the source, the origin of this fraction. But in 1968, as you can see in this paper published in Clinica Chimica Acta, it was described an abnormal hemoglobin in red cells of diabetics. This is the origin of the story, but in the 70s, some structural identification efforts have been done. We can realize that the story of the so-called Amadori products. I will show you the Amadori products and the famous Maillard reaction. And it was recognized the role and the issue of hemoglobin glycated as a major fraction formed by binding glucose. I like to highlight that we have to speak about glycation, no more about glycosylation, the wrong term. So glycated hemoglobin, HbA1c, derives from, firstly, the addition of glucose. You know the story of the shift base, unstable binding, and through the Amadori rearrangement, we have now finally the Amadori product, the stable HbA1c, glycated hemoglobin, and eventually in the late stage, some other advanced glycated products. So glycated hemoglobin, starting from this point, is a well-defined structure, the binding of glucose to the N-terminal valine residues of the beta globin chain, and the story of other glycation protein has been further recognized. Some other examples are the story of fructosamine and glycated albumin. You can see in this slide. But the other Amadori products, other than glycated hemoglobin, should be viewed as less important from a clinical practice, are markers of a shorter period, and are more sensitive and less inert than the glycated hemoglobin. So the limited indication in real life diagnosis and monitoring up to now has been recognized. We can say that glycated hemoglobin, HbA1c, is a complex molecule, as you can see in this slide. You can recognize the number of amino acids in the alpha and beta chain of hemoglobin. So it was recognized the need and necessity of a strict definition of the molecule for any further standardization effort. The third era is the times of clinical enthusiasm, starting from the 70s to the 90s. Because in 1962, it was recognized the role in diabetic patients. In 1968, elevated values of glycated hemoglobin in red blood cell was confirmed. In the 70s, the suggestion to perform a periodic monitoring was proposed, and later on, starting from the famous DCCT 1993 and UK PDES in 1998, large epidemiological trials, the relationship between glycated hemoglobin and the degenerative complication of diabetes mellitus has been finally well recognized and established. So glycated hemoglobin should be called or viewed as a gold standard in many diabetic survey studies and clinical practice too. Is an index of glycation and glycemic balance starting from 4 to 8 weeks before testing, before sampling. And it was proposed, some reference rate, some limits for good glycemic control, and eventually poor glycemic control on the basis of glycated hemoglobin. This is a famous paper published in New England Journal of Medicine in 1993, September 1993, in which intensive therapy of patients with diabetes on the basis of the monitoring and the value of glycated hemoglobin was found to decrease the complication, retinopathy, and neuropathy in the range between 35 to more than 70%. So an impressive improvement in the treatment of diabetes complication based on glycated hemoglobin measurement. And you can see at the time it was called glycosylated, but you can see the relationship between the rate of severe hypo or beta, the progression of complication, and the levels of glycated hemoglobin. And you can appreciate in this slide the difference between the conventional treatment of patient and the intensive treatment based on the monitoring of glycated hemoglobin. Very impressive data, a real clinical improvement in patient treatment. And you can see that the data confirm a reduction about or more than 25% of the complication rate by decreasing only 1% or more the levels of glycated hemoglobin. Impressive data. The data were confirmed in many other studies later on, you can appreciate in this slide. And we are speaking about complication in kidney, nervous, heart, and eye disease. And this is a relationship between the so-called measured mean glucose and glycated hemoglobin as an estimation of glycemic and metabolic control. And even the fluctuation of glycemia in comparison to glycated hemoglobin was found to be a very important issue, as you can appreciate in this slide. Therefore, starting from 2011, as you can appreciate in this slide, in the American Diabetes Association recognized the role of glycated hemoglobin, adding this test as one of the major criteria used for the diagnosis of diabetes, not only for monitoring, but also for the diagnosis. And you can see that the other two parameters are fasting plasma glucose, of course, and plasma glucose 2 hours after the oral glucose tolerance test, OGTT. The WHO, in the same year, recognized the importance of glycated hemoglobin, not only for the monitoring, but I like to stress this point, for the diagnosis of diabetes. So, the clinical role of glycated hemoglobin moved from the follow-up monitoring to the diagnosis, so changing the paradigm of diabetes diagnosis and treatment. And glycated hemoglobin has been recommended for diabetes screening according to the several, including WHO and the American Diabetes Society guideline. So you can see in this slide, emphasize the increasing risk and the role of glycated hemoglobin in diabetes, not only diagnosis, but prevention. This is much better emphasized in the recently developed and released guidelines in 2021, this year, by the American Diabetes Association, in which you can see the role of glycated hemoglobin as a glycemic target regarding disease duration, expectancy of life, comorbidities, and so on. So very important role in clinical practice. And once again, in the last release guidelines, a central role for glycated hemoglobin has been recognized. As you can see, a level higher than 48 millimole per mole, or 6.5% of glycated hemoglobin, is very important and should be measured in any patient with the suspicion of diabetes. The criteria for defining even pre-diabetes include right now glycated hemoglobin. So not only for the diagnosis, but for the prevention and risk evaluation. And this is a relationship between the estimated average glucose and glycated hemoglobin, expressed in both milligram per deciliter or beta millimole per liter. So in the assessment of glycemic control, HbA1c measurement is absolutely recommended. Glycated hemoglobin is a metric used to date in clinical trial to demonstrate the benefits of an improved glycemic control. And as you can appreciate, the recommendation to assess glycemic status and to monitor the glycemic status at least quarterly is very important. So not just 1 point, but every 4 months should be monitored the level of glycated hemoglobin. Of course, the same guideline recognize the limitation, in particular, and we will deal after all thereafter, with the variability due to some hemoglobin variant, red blood cell turnover increased or decreased the red blood cell turnover, but in particular increased blood cell turnover. So the strategy and diagnosis is based absolutely not only on the previous criteria, but also on the measurement of glycated hemoglobin. It's very important to recognize this fundamental step, moving glycated hemoglobin for patient monitoring to the diagnosis and prevention of diabetes. And there are many advantages in comparison to the blood glucose measurement. No fasting sample is required. This is very important. Lower biological variability. HbA1c is an integrated reflector of glycemia, as the internationally standardized methods were recognized with the reference network, which provide the target for HbA1c measurement. There are some inconveniences, as for any other laboratory test, some interference due to hemoglobin variants and altered red blood cell metabolism. Someone say higher cost, but it's no more. This is the story. So we can finally say that HbA1c is a global biomarker of diabetes. This is a very important statement. Once again, the advantage emphasized in this slide are lower biological variability and less pre-analytical instability. Very important from not only laboratory, but also clinical point of view. No need for fasting or time samples. And now, what happens before standardization? There was a Tower of Babel problem that was well recognized, and the conclusion was need for standardization. And the time of standardization briefly are well recognized by the effort done by the international standardization managed by, particularly by the International Federation of Clinical Chemistry and Laboratory Medicine, IFCC, defining the HB species measured, defining and validating a reference measurement procedure. And you can see that starting from 19 to 2000, the standardization working group was developed. And finally, in 2002, the definitive method was released. So the measurement is well established, is a beta N-terminal hexapeptide expressing millimole of HbA1c per mole of HbA plus HbA1c, and the reference procedure is based on HbAlc, mass spectrometry, or electrophoretic capillary. And we know that the test standardization is based on the traceability hierarchy that we know. So this was done. And the principle is different from the national standardization group procedure that was developed particularly in the US. The IFCC program is much better defined. The sustainability of the reference system is maintained by an international network of laboratories that assure the continuity of the reference measurement procedure, traceability of all commercially available assays. And I stress at this point, all routine methods are now traceable to the reference measurement procedure. This is a very important standardization goal and success. So it's very important to recognize the side effect changing value reporting. And I will show you now how the master equation make possible the standardization of all other commercially available assays and other national initiatives. So this was well recognized in this consensus statement, in which the new IFCC reference system has been recognized to be the only valid anchor to implement standardization, and even in real life practice. So this is another famous paper published in Clinical Chemistry in 2011 on the status of hemoglobin A1c measurement and goal for improvement. We moved from chaos to order for improving not only laboratory testing, but particularly diabetes care, as you can see in the title of this paper. And if you look at the measurement of the improvement of method performance starting from 1993 to 2010, we can see a slight measurement, but it's more impressive the measurement in 2018 in the over time, decreasing the imprecision. You can see the terrific decrease of the imprecision starting from the 2000 to from now. And this was also recognized in this paper published in Clinical Chemistry. Is a European trial investigating the performance in more than 2,100 clinical laboratories across 17 countries and 24 manufacturers. And the improvement is absolutely, you can see, is absolutely evident. I like to stress the data provided by the Center of Biomedical Research. I'm the chief of this center in Italy, providing the data about the bias and the imprecision that is absolutely good in Italy. More than 84 laboratories applied in this survey. So we have different analytical systems based on immunoassay, ion exchange HbAlc, boronite affinity HbAlc, enzymatic assay, point of care testing. I like to stress the point that all these assays should be standardized against the IFCC reference method. So we can discuss about the bias and interference of this assay versus different HB variants and eventually other possible interferences. This is a paper dealing with the effect of common hemoglobin variant on HbA1c measurement in China. You can see the type of variant. Of course, this is an ion exchange or capillary electrophoresis method, demonstrating not only the peak of the glycated hemoglobin, but the other variant. And what we know is that some methods may detect the presence of hemoglobin variant, but what is more important is to adopt methods in clinical practice that are not affected by this type of interference. This should be clarified. So the enzymatic assay presents some advantage, no analytical interference from HB variant. The challenge is that they are unable to detect the HB variants, but this is not a question about the value of the HbA1c as a target for the diagnosis and monitoring of diabetics in diabetic patients. And we have to recognize the different distribution of HB variants in the world. And we have to recognize that once again, enzymatic method minimize the interference from hemoglobin variant. This is in particular the recognition site with the MALDI HbA1c assay method. What about point-of-care testing? This paper has been published this year in Clinical Chemistry Laboratory Medicine. It is a journal in which I was appointed. I'm still editor-in-chief. This is a comprehensive study. And this study shows that out of 6 point-of-care analyzed, only 2 met international quality criteria. 2 were borderline and 2 were totally unacceptable. So the problem point of care is to evaluate which type of point of care are you speaking about, and to eventually understand that not all point of care testing are equal. This is a paper I showed you demonstrating the sigma metric of the different point of care devices. In terms of bias particularly, we can see there are some dramatic problems. Another paper published in Diabetes Research and Clinical Practice very recently stresses the point of the comparing IFCC calibrated HbA1c from laboratory and point of care testing found significant differences. And once again, we can take care about this. So the implementation of new HbA1 numbers, we have validated and used the new numbers, moves from the traditional percentage of total hemoglobin to the recommended units, as you can see, millimole of HbA1c versus mole of hemoglobin. And we have solid data about the reference range and the limits for good glycemic and poor glycemic control. And in many countries, the implementation of the new international standardization reference and units have been totally performed. But we need still education communication with clinical national societies and patients. So finally, we are in the times of expansion, a new challenge about analytical aspect, how to measure, evaluate method performances, but and to establish quality target, external quality assurance are very important, and about clinical aspect, because we can use the data in many clinical situations, not only for the monitoring, diagnosis, but also screening. So about the analytical aspect, we have to use automation to be sure that point of care testing are really performing, complying with the recommendation. Global improvement of performances are needed. Quality control and quality assessment trial, particularly based on commutable materials, and the strict quality targets. This is really a paper published recently from my colleague Philippe Gillery, one of the most recognized authors and scientists in this field. It demonstrated the most assays are fairly accurate and meet the total allowable error, particularly if we use fresh clinical specimen, much better than frozen clinical specimen. But there is a room for improvement, as demonstrated in this paper, on quality targets for HbA1c and sigma metric. And we can conclude this that the imprecision goal is to reduce the imprecision under 2.8%, and the total error should be lower than 8.6%. It is possible to realize this goal. Finally, I show you that the research, particularly in the field of diabetes, is going on. These are the spectra from diabetic patients with a particular mass spectrometer, MALDI, instrumentation. We have published some years ago, and you can appreciate the difference between patients with good metabolic control and poor metabolic control using these particular peaks. So the end stage glycemic product should be further evaluated. Up to now, limited role in clinical practice, but for research, there are some further effort to be provided. This is another paper that we published some years ago. You can see the difference between patients with and without complication. Diabetic patients, of course. What do we have to do? There are still some analytical concerns, but I have already explained to you how we can overpass this point. We have to better use in clinical practice the measurement of glycated hemoglobin. And sometimes we have to explain to the clinician that some modification of red blood cell lifespan, particularly after blood transfusion, should be taken into consideration. This is a very recently published paper. You can see how important is glycated hemoglobin, evaluating the time or range regarding the glucose levels, that is the metabolic control. So once again, glycated hemoglobin is increasingly important in clinical practice. And even in this pandemic, COVID-19 pandemic, the importance of hyperglycemia as a complication of the infection has been recognized. But unfortunately, you can see that the monitoring of diabetic patients, particularly between April and May last year, was decreased due to the pandemic. So it's very important to continue the monitoring of diabetic patients even in this pandemic year that fortunately should be finished quite soon, hopefully. So some take-home message. Glycated hemoglobin is an important fraction of hemoglobin derived from a non-enzymatic reaction. We know that the assays are now standardized at an international level. We have a traceable reference measurement procedure. Hemoglobin, glycated hemoglobin is used as a long-term retrospective marker, but also as a diagnosis marker. Results are interpretable in most clinical situations, and therefore we can conclude that HbA1c is one of the most powerful biomarkers discovered and implemented in clinical practice during the last 5 decades. If you have time, you can read this paper. It is a nice review by Philippe Gillery, published in Clinical Chemistry Laboratory Medicine. Thank you so much for your attention. I thank once again Mindry for inviting me to deliver this lecture.
Thanks a lot, Professor Plebani, for this fantastic talk. It is really nice to see from the knowledge you have about this topic and how it helps to all of us. Thank you so much. I have a question for Professor Plebani.
Yeah, okay.
Yes, elevated fetal hemoglobin levels has been reported to interfere with results of some hemoglobin A1c methods. What kind of patients may have hemoglobinopathies with high hemoglobin F concentrations? You have to open your microphone, Professor Plebani.
Okay, now because okay, I'm ready to answer, Ramon. So the question is right. We have increase of fetal hemoglobin in some hereditary persistence cases, but even in some pathologic conditions, particularly in thalassemia and leukemia. So it's very important to recognize in this case that values higher than 2% should be associated with this type of pathologies and clinical status.
Okay, we have another question. In some countries, point-of-care instruments are widely used in laboratories and used for diagnosis and monitoring of diabetes mellitus. What is your opinion about point-of-care testing methods?
As I tried to explain in my lecture, there are different types of point-of-care tests and different type of performances of this point-of-care testing. In general, the analytical performances do not allow the diagnosis, the use of glycated hemoglobin for diagnosis, but only the monitoring with point-of-care tests. And all, particularly if you select a good point-of-care test devices. In my institution, we are using point-of-care only for pediatric age monitoring. And this is not for, is particularly related to the capillary blood collection that is less invasive than the traditional one, but is a very limited use. We prefer to use central lab laboratory tests.
Thank you so much, Professor Plebani. It was very nice. Okay, and now we are very pleased to give the floor to Dr. Tim Yin. He is a clinical specialist in MindRay IBD. He was previously working as attending physician as a medical scientist in the Hua Mei Hospital of University of Academic Sciences in Ningbo, China. His speech will talk about anti-interference capacity of MindRay enzymatic hemoglobin A1c against common hemoglobin variants. We are going to ask after his talk some questions to Dr. Saadet Kader, and Dr. Plebani maybe will be another one, but I know Dr. Plebani will have to leave at 11:45 or something like that. Okay, Dr. Tim Yin, the floor is yours.
Thank you, Dr. Raymond. Okay, my name is Tim Yin. I'm so honored to have this chance to share this information about anti-interference capacity of MindRay enzymatic HbA1c, especially against the commonly seen hemoglobin variants in medical practice, which are HbS, HbE, HbD, and HbC. Well, to be more precise. As for the background, diabetes mellitus and HbA1c. Well, I know we are all familiar with this disease, diabetes mellitus and HbA1c, but I'd like to show some data here. Well, this map is from the report from IDF, International Diabetes Federation. And we can see that 2019, there were 1 in 11 adults have diabetes, which in the entire world is 463 million people. What makes this figure more worse is the prediction of the prevalence in the future. Well, I call this a horror story. We can see that 2045, which is 25 years later, we see the increase rate 33%, 55%, 143%, 96%. Well, diabetes mellitus at this point is a global health burden, and in the future, it will be a more significant health issue all over the world. But fortunately, we have HbA1c. This is a great marker for the entire management of diabetes mellitus. And well, as Professor Plebani has introduced, we know that HbA1c, the glycated hemoglobin, is, well, the glucose react with the N-terminal of beta chain of a hemoglobin molecule. And after a certain time of reaction, it will form a stable structure. And we test this structure to find the, well, relative average glycemic control, glycemic levels over a period. Because of some features of HbA1c, it's really a good marker for the management of diabetes mellitus. For the first one, it's really easy to test. One time of blood collection and 1 tube of blood sample could get this test done. And also, this test does not require fasting. We know that, well, the commonly known feature of diabetes mellitus is a relatively high blood glucose level. But for some of these patients, the most severe acute complaints is low blood sugar level, hypoglycemia. And well, to be honest, a relatively long period of fasting could trigger hypoglycemia and which could endanger the life of patients with diabetes mellitus. Also, as Professor Plebani has introduced, we know that HbA1c could reflect the glycemic control over a period which is approximate 3 to 4 months. Unlike almost all the other test methods, they only reflects certain time point of the glucose level of the patient. And because of these features, HbA1c is recognized and recommended by many guidance for diabetes mellitus screening and diagnosis. This table is from ADA guideline. This is the 2019, but the updated, the recent published one is the same diagnostic cutoffs. I suppose you still remember that figure, 463 million. Still, according to IDF, almost a half of them doesn't know they have diabetes mellitus. And as a really easy to practice to test marker, HbA1c is very useful for the screening and diagnosis to identify an individual, a normal person without diabetes mellitus or pre-diabetes and patients with this illness, diabetes. What's more, according to different guidelines, and they published different glycemic control targets with HbA1c for different type of population, for different type of patients. Well, HbA1c is also a great marker for therapeutic monitoring to assess the patient's treatment to improve the treatment, to make sure that they could have a better medical outcome. And when, for the first time, I see this data, I not double checked, I triple checked because it's really marvel for the data. HbA1c decrease by 1% could decrease the diabetes mellitus related illnesses or medical conditions significantly. But for instance, death related to diabetes down by 21%, myocardial infarction by 14%, microvascular complications, which are really commonly seen in medical practice for patients with diabetes mellitus. For instance, the renal disease, the retinal disease, and so on. And 1% decrease of HbA1c could bring down the microvascular complications by 37%. This is really useful for a marker in the therapeutic monitoring. And well, I see that we all know that HbA1c is a good marker, but it's not the ideal one or the perfect one because it could be interfered by many factors. For instance, we can see from this table, it's from an article, a review article. Many medical conditions, many medications, hemoglobin variants could interfere the test results of HbA1c. For most of them, could be altered, could be changed by the change of medication, by the change of the patient's status. But hemoglobin variants could not be changed. So for the interpreting of the test results of hemoglobin A1c, we should be aware of these variants. Well, we know that for the general adult the most of the hemoglobin are hemoglobin A and A for adult. Only a slight form of A2 and F, HbF, is mainly seen in the fetus and newborn. As for hemoglobin variants, mainly they are some sort of changes in the structure of beta chain. Well, which means it's the change of hemoglobin A. And well, for instance, hemoglobin S and hemoglobin C are all the replacement of the normal amino acid in beta chain in the 6th position. For hemoglobin S, glutamic acid is replaced by valine. And as for hemoglobin C, glutamic acid is replaced by lysine. Well, because of the existence of the variants, HbA1c test results could be interfered. And let's see the distribution of hemoglobin variants. We can see that for many regions and countries, some of these patients could be interfered because of the existence of hemoglobin variants S, C, E, etc. And when we are interpreting the test results of HbA1c, for the medical practitioners, especially in these areas and regions, they should pay more attention. And well, as introduced by Dr. Raymond, I suppose you still remember that I worked in a general public hospital in China for 5 years, which is located around here. And to be honest, in the 5-year practice, I didn't see any case of hemoglobin variant. But for the medical practitioners in these regions and the countries, well, sometimes hemoglobin variants should be considered, and for some of the cases, it could interfere the test results significantly. Well, because of this, NGSP, this organization, publish this information on their website to review the effects of hemoglobin variants and the elevated fetal hemoglobin, HbF. Well, this is part of the table. For many manufacturers and for many different types of analyzers, we can all find some information about the interference from different types and for these commonly seen types of hemoglobin variants. Well, we all know that there are different methods for hemoglobin A1c testing. Based on the principle, mainly there are 2 types. The first one is based on the electric charge, HbAlc and so on. And also there are some methods based on structures, such as immunoassay and enzymatic assay. Even after the standardization of IFCC, after this standardization, many test results of HbA1c are comparable in different laboratories using different test methods. But once some samples or some patient has the hemoglobin variants, this could be, well, not that standardized as the harmonized and comparable in different laboratories, especially when they are using different testing methods. And well, MALDI choose enzymatic method for our testing of hemoglobin A1c. And also on the same website, NGSP, well, there are 2 documents. The first one is list of NGSP certified methods From this document, we can all find that Mandri, Abbott, Saxui, Hitachi, Siemens, and many other and more manufacturers are using enzymatic method. Therefore, I call this a new trend. Well, the main reason for enzymatic method to become a new trend is because of the methodology advantages to fight against the hemoglobin variants. Well, we can see that this shows the sequence of amino acids of a normal beta chain. This is the normal chain for most of the general adults. At different positions, the primary amino acid could be replaced by other amino acids to form different types of hemoglobin variants, HbS, C, Ed. And well, the major reason for enzymatic method to minimize the variant interference is because, well, take Mandri for example. We use a specific enzyme to recognize the structure between the second and the third amino acids. After pre-treatment with this enzyme, we therefore test the first two amino acids for the further measurement. Because of such kind of recognition of the first two amino acids, well, all the replacement of the amino acids after the third position could not interfere the further measurement afterwards. And let's move on to see some internal study and some data from Mandri, enzymatic HbA1c. Well, for all these samples, we collected from Queen Beatrix Hospital, which is the primary European reference laboratory for glycated hemoglobin. And as for the values, for the variants and for the HbA1c value, they are all assigned by IFCC calibrated instrument or testing methods. Well, which means for the comparison, the reference data, the reference result, we could consider them as the true value of HbA1c. And we use BS800M for the internal study, the comparison. And the criteria of acceptance is the relative bias should be less than 5%. And let's see, this is the table of all the test results. Well, we can see that at different level of HbA1c, 6%, 9%, the relative bias are, well, way small than 5%. Well, as for HbF, it's another story, and I will give detailed information later. For the first one, HbS, well, we can see that the x-axis is the true value, which is assigned by the IFCC calibrated instruments. And the variance of HbS in each sample is around 40%. And under such kind of situation, the test results of Mandri, we can see that it's really close to the regression line. And the difference between the Mandri test result and the estimate result, the true value is quite small. Also, About the relative bias, they are all within the limit, 5%. And the reason, as I've already explained, the 6th position replacement of amino acid could not interfere our test, our measurement, because the measurement after the pre-treatment are only focused on this structure. As for HbE is quite similar to HbS, the true value and the test results of boundary. As the proportion of HbE, I'd like to introduce this one. 94%, which means for this patient, 94% of the patient's beta chain have the amino acid replacement. And even under this circumstance, the relative bias is only 4.3. And also, we can see that for different test values of HbA1c, from about 5% to about 10%, the relative bias are all smaller than 5%. The test result is really close to the true value. And as for the reason, still similar. This replacement could not interfere our test, our measurement, our method. HbC also is similar, true value. And for the MALDI test results, they are all near the regression line. And also, it has the same proportion, similar proportion of HbC, 97%. Even, this is quite high. For some cases, it's extremely high as the proportion of a variant. And this doesn't change the test result or interfere our test result. Still, the relative bias are always in 5%. And the same reason, this replacement by lysine could not interfere our test result, no matter the proportion of HbC and the proportion of normal beta chain. As for HbD, we can see that the performance are still good enough, and R squares are 0.9812. Still, for different value of HbA1c, from 5% to more than 9%. The relative bias are all within the limit, 5%. And just like the previous 3 variants, these changes of beta chain, we see that for the general adults, HbA2 is relatively low in the proportion. And also, HbF should be lower within, I suppose it's 5%. But all these samples which feature, I call this the dose dependent. And chart could give a more clear view of this trend of this feature. The axis is not similar to the previous variants. This is the proportion of HbF. We can see that as the proportion increases, the relative bias increases. Well, the major reason for this phenomenon is, well, as for the definition of IFCC, the glycated beta chains are recognized as glycated hemoglobin A1c. But we know that for adult hemoglobin, it has 2 beta chains, but for HbF, it doesn't have beta chain at all. Because of this feature, not only for the enzymatic method, but also for many other methods, HbF interference is still a problem. And we are trying to solve this problem. But, well, at least at this point, HbF interference should out. A brief summary. HbA1c is a good marker for the screening, diagnosis, and monitoring of diabetes mellitus. HB variants and HbF can interfere the HbA1c testing result. Enzymatic method of Mandry DS system can effectively avoid interference from HbS, HbE, HbC, and HbD. These 4 are the commonly seen hemoglobin variants in practice and all over the world. Similar to others, enzymatic methods cannot solve HbF interference at this point. But I suppose after the future investment and the future study, there could be some other method or some other technique could help all these methods to solve this problem. Thank you for all your attention. And it's a great honor to give this speech. Thank you.
Okay. Thank you, Dr. Tim Yin. It was very nice presentation and very clear to see how the interference, the hemoglobin variants interference can affect the glycated hemoglobin and how this enzymatic method can avoid that. Okay, now let's do let's share my screen again. Let's see. Let me finish with some considerations about the use of the glycated hemoglobin. Just to mention that the distribution of malaria in the world with a higher frequency of hemoglobin variants, we know that one of the mechanisms of defense against that, when it was not any treatment, was to, in these areas there are an increase, a higher frequency of hemoglobin variants. And I have been in Italy and some areas of like Sardinia, but also in Sicily, 40% of the population has an hemoglobin variant. For this reason, in some of the regions of the world, this problem of the hemoglobin variants is really important. And another topic that I would like to add to everything has been said is that nowadays many local labs has been closed and they send the samples to a central lab. Of course, the transportation, even if we have today methods to avoid the glycolysis, it's another reason to order hemoglobin A1c or glycated hemoglobin. And when you know your patient samples have to be transported to a reference lab that sometimes needs 10 hours, 15 hours of transportation, maybe you have to consider to determine the glycated hemoglobin. After that, it's a question, it's a part of the meeting to give the floor to the audience to send some questions, some answers. We have been asked Dr. Plebani for his questions about his presentation. Let me see if there is any other one in the chat. Let's see. Sorry. Let's see the chat. if there's any answer. If not, we are going to go for the questions for Dr. Kader. Let's see. Tim Jean is a question to Dr. Jean. Okay, but not anymore for. In this case, we are going to go for the questions for Dr. Kader. Let's see. There is a question for Dr. Sader Kader. What kind of patients may have more hemoglobin derivatives, such as carboxylated and acylated hemoglobin, labeled hemoglobin?
Okay, firstly, I want to explain what are the meanings of carboxylated hemoglobin, acylated hemoglobin, and labile hemoglobin A1c. Carboxylated hemoglobin is formed by the reaction hemoglobin with cyanide, a product of in vivo urea dissociation. It is found high levels in patients with renal failure. Chronic renal failure develops in many diabetic patients. So for the laboratory and manufacture, we had better evaluate the anti-carbon-related hemoglobin interference ability of hemoglobin A1c test. And acylated hemoglobin usually occurs in patients receiving excess aspirin drugs. Aspirin is cornerstone treatment for the prevention of diabetic complications such as cardiovascular disease. So for the IVD manufacturer need to evaluate to improve the anti-acylated hemoglobin interference ability for hemoglobin A1c test. And labile hemoglobin, what is the labile hemoglobin? Labile hemoglobin A1c is also known as pre-hemoglobin A1c or labile hemoglobin 1c or pre-glycohemoglobin. It is an unstable form as HbAs formed during non-enzymatic glycation of hemoglobin. The concentration of labile fraction varies with acute change in plasma glucose level. Immunoassay, enzymatic method, and affinity chromatography are not affected by labile hemoglobin ABC fraction. Though the HbAc method can separate the labile hemoglobin A1c fraction in some conditions, such as blood transfusion, it may result in misinterpretation of hemoglobin A1c values. Thank you.
Okay, very good. Before to go for the questions for Dr. Jean, we have a question for all the speakers. Which anticoagulant you recommend to use for the hemoglobin A1c analysis?
May I see? May I answer?
Absolutely, Dr.
Yeah.
Professor Plebani.
Is the recommended anticoagulant and widely used.
Pardon?
EDTA.
ADTA, okay, very good. This is the answer, is the best anticoagulant. Perfect. And now the questions for Dr. Tim Jean. How does hemoglobin variants affect hemoglobin A1c results? Will it cause falsely lowered A1c or falsely elevated A1c? I think you have answered this question with your talk, but okay, again, I have to transmit you this question.
Okay, thank you for the question. And we know that normal human hemoglobins made up about 98% of HbA, hemoglobin A. And well, there are 4 chains to form the molecule of hemoglobin. For hemoglobin A, HbA, there are 2 alpha chains and 2 beta chains. So for the normal population, when we are testing, no matter about HbA1c or Hb itself, because of the definition of IFCC, we only test the glycated beta chain, well, which means any difference or any changes of the structure of beta chain could cause interference, could affect the HbA1c test results. And as I mentioned, well, there are mainly 2 methods to measure HbA1c. one is based on electric charge, and the other one is based on the structure. Well, as the structure changes, this change of beta chain could cause, well, sometimes maybe falsely low test result of HbA1c. And also, for some cases, the replacement, even for one amino acid, which could cause a significant difference between the electric charge. So they could give interfered test result, not a true result as well. So for some of the cases, if the structure changes, well, because of all these testing methods of HbA1c we can find it on the market has certain limits. So they could be interfered and cause falsely low results. And even for us, we use enzymatic method. If a patient have a very high proportion of HbF, so which means beta chain could be more or less than normal. Also, the test results could be much lower. So I suppose this will answer the question. Thank you.
Okay, good. There is another question that is, I can answer myself. That is, what is the difference between glycated and glycosylated hemoglobin? As Professor Plebani has said in his presentation, in the origin, some people use the term glycosylated hemoglobin. Now, practically in all the articles in the world, it's used the glycated. This is just a question of terminology. There is another question for the speakers. Which anticoagulant, which differences between ADTA, D-potassium and 3-potassium for the determination of glycated hemoglobin? For me, it's not any difference, but if you want to add anything, the speakers here. Dr. Jean or Dr. Kader?
Well,
I'm thinking, and
still,
is there any difference? I'm thinking about.
Okay, still, when I was in the practice, we mainly use two potassium EDTA, and I suppose there will be no significant difference because we all know that when we are testing HbA1c, we collect the red blood cells and then break them down to let hemoglobin, no matter it's glycated or not glycated, to do the further test. So based on this principle, I suppose there will be no significant difference between these two kinds of anticoagulants, I suppose. Thank you.
For me, it's the same.
I think, yes, I want to add something to Tim. Thank you, Tim. And I agree with you. And for me also, there is no difference. D-potassium, 3-potassium, it is the same because I also make a practice in my laboratory. The results are the same. I couldn't see any differences.
Okay, there is another question for the speakers. I think it was answered again with the conference of Professor Plebani. Reviewing the video, you have the answer. But they ask, what is the gold standard for the determination of glycated hemoglobin?
IDMS spectrophotometry, I think. IDMS spectrophotometry is the gold standard for the glycation hemoglobin.
Okay, good, very good. The last but not least, I think, is, let me say, yeah, which point of care, I think he said in his presentation, is not Professor Plebani in this moment, because he advised us that he has to leave for another meeting. But if reviewing the video, you will see. I don't want to enter in that because this is a commercial thing, which companies, but he said clearly that when they evaluated several point-of-care instruments, only 2 were giving a good result, and the other 4, one of them was bad, and the other was very, very bad. But I don't want to enter on that. I think reviewing the video of Professor Plebani, you will be able to see that point-of-care thing. I think that's all, but let me see. HbAlc and enzymatic assay. I think this can be a question for Dr. Kader, because you have evaluated Bio-Rad and enzymatic assays. You can answer these questions. Is this any difference between enzymatic assays and HbAlc?
Could you repeat, please, because I couldn't understand you very well.
Yes. What is the difference? The question is HbAlc and enzymatic assay. Any difference?
HbAlc and LCMS between
no, HbAlc and enzymatic assay, like mean ray determination. What is any difference?
HbAlc and mean ray. For immunoassay, you're asking between the two measurements differences. I think.
Like
okay?
Bio-Rad and mean ray.
Okay. In our study, we couldn't see any differences, because when we evaluate the results of the hemoglobin A1c, there is no differences. Just for example, I have found hemoglobin at 6.4 in HbAlc, in mean ray also 6.3. No differences, just a little differences I can see in my study.
Yeah, I have seen in your slides that the difference between mean ray and the other was 0.1.
Yes, you are right. Also, our regression analyzer are very high, and 0.98, 99. Yeah, and we really have a good compatibility between devices. So I'm very glad to have this result.
Very good. There is another question.
I use the mean ray in my laboratory, and I can trust hemoglobin A1c results after this work. After this study, I can trust my hemoglobin A1c very well, because I'm working hemoglobin A1c in online pretreatment. In the clinical chemistry analyzer, I'm working this hemoglobin A1c, not HbAlc device. So I have a question in my mind. I think there is a difference, and clinicians maybe always said to me, hemoglobin A1c are higher or low. But now I have been mean ray BS 800 for 3 years, and I don't have any problems. Our clinicians all are glad to our hemoglobin A1c results. So I'm okay for me. HbAlc is the same for me. Mean ray BS 800M.
Very good. The other question is which sigma? Let me see. Which sigma is? Let me see if I can read again. Which sigma is recommended? Yes, the question is, what sigma is recommended for clinical chemistry laboratory? If any of you, maybe it was for Professor Plebani, but you can answer this question, which sigma?
Normally, 6 sigma is the best. 6 sigma. If we have a 6 sigma, we are the best laboratory. But I think it changes the laboratories to laboratory, because, for example, I have a small laboratory. Just I have one analyzers every part of chemistry. So I think it is not a constant number, in my opinion. Of course, 6 sigma is the best, but I think nobody can realize the 6 sigma, because it's really hard to take 6 sigma.
I have, you know, Six Sigma is one of the goals for all the people working in a, not only in a laboratory, in a company, in a, you know, in any field in the world. As you said, for me, Six Sigma is a way to control your errors. The goal is 1 error in 1 million procedures. That, of course, is difficult, and is difficult because it's also very expensive to achieve. But for me, the important is to evaluate your errors and to analyze the errors, and moreover, the more frequent errors, the 80% of the errors that happens in your lab, and to improve your Six Sigma, improve every year, every 6 months. What is the concept of Kaizen, continuous improvement. For this reason, for me, every error has to be analyzed with a group of people. And if you don't have the answer, to ask for the big specialists and professors. But the important is to improve your Sigma.
Exactly. I can add something because I made a Six Sigma and a poster, and I evaluated my immunoassay results, evaluated, and my Sigma showed me 3 and 3.5, 5. I have a 3.5, 5. Really, no manipulation, no manipulation. And I also trust me, because I have found 3 Sigma. I have saved this 3 Sigma. I don't understand why, but I have found 3 Sigma. So I think I have to improve, but it's really quite hard to improve yourself for 6 Sigma, because if you work a small hospital, because I work a small hospital, so I don't have advantages, and nobody understands biochemistry's importance. So it is the problem. I couldn't speak to doctors to my my problems. They don't understand. They don't care. So it is a quite hard zone for us, for small hospitals, I think.
Okay.
And also,
another question.
Just like Dr. Raymond has explained, when I in that hospital, we did that certification, ISO 15189, and also it has a similar thought, just like Dr. Raymond has mentioned, continuously improvement of the Sigma metrics of the quality of the laboratory, rather than a cut-off value to see that, well, you are better than this value, you are good laboratory, and lower than this one, okay, you are not.
Yeah, I agree with that. This is the idea of the concept of Sigma. I have learned, but for all the audience, very early in my career, in 1989, in the Jurassic time, okay, that in the Mayo Clinic, the Mayo brothers set up in the early part of this century, the last century, in the 1950s, 1960s, they set up, they wrote all the procedures. In that time, nobody was talking about ISO, but the important is they were reviewing all the processes, of course, based in errors, but all the processes from the size of a door that permits to pass the patient very well from one place to another, from the place that has to be the tools in the offices, from the size of the histories, and they were reviewing all the processes in the Mayo Clinic every 2 years. Every 2 years for 6 months, 1 hour per week, they were meeting the people involved in the process to improve it. And they were having, after 50 years, when I was there, they were reviewing for 40, 50 years. They had 20 revisions of the procedure for everything, how to the historical clinic, and a group of experts that is involved, everybody involved in the process, review the process. And you number the process, and you continuously improve every time. And that is the goal for all the people in all the companies, and of course in the lab, because one of our errors can condition the life of the patient. Okay, let's give another question for the audience, for the speakers. If there is any special protocol for hemoglobin A1c estimation for COVID patients?
In our hospital, no, we don't separate to patients. Just work the same. I think, I don't know. There is a protocol. Or no? I don't know. Dr. Tim, do you know? I don't know.
Well, I suppose for COVID-19 itself, it's still some sort of a mystery because on many fields, we are still lack of enough evidence to file such kind of guidance for the medical practice. Well, for instance, to establish certain recommendation for HbA1c in COVID-19 patients. And I believe that as Professor Plebani in his presentation, we all know that HbA1c from the beginning, it's approximately 1950, yes, until after almost 50 to 70 years, because based on the accumulated evidence, the medical practitioners could put this parameter in the screening, in the diagnosis, and in the therapeutic monitoring. So I believe to file such kind of recommendation, maybe there still need more evidence and more research in this pandemic for patients with diabetes mellitus to give them a proper HbA1c value or target. Thank you.
Okay, we have another question for both. How much time can we store a sample for the estimation of hemoglobin A1c in the lab? I have answered a little this question because I said that glucose, the determination of fasting glucose is stable for a short time, and you need to add some additional substances or to extract the serum, separate the serum, and it's complicated. But can you answer what is your estimation of stability, sample stability for hemoglobin A1c determination?
I'm thinking.
I think it's very stable. Huh? You can transport the sample for 24 hours, for 36 hours. That is stable, very stable.
24 hours. My samples are stored for 24 hours, but there is no change between. 24 hours is okay, I think.
Okay, very good. Let me see if there's any other question. How long we can keep the samples? That was answered. Okay, we will answer the questions because it's coming more and more, and that will be very delayed. But I think we can stop the questions and answers, and any other questions will be answered. We keep all this list of the chat, and we are going to answer to all the other questions. Thank you so much for the speakers. It was very good to share this time with you, and with we arrived to 660 people attending this meeting. Very successful attendance of the meeting, because we know everybody is very busy. And thank you so much. And thank you for the audience.
Simon. Thank you so much to you. Thank you, participants, for listening us. Thank you so much.
Thank you.
Bye.
Take care.
Sorry. I have to share. Sorry, I have to share one quote for the people to. Sorry, it's important that I share that. You have this QR code for the speakers to ask for a survey in 1 minute. That will be very important for Minray to understand what we can improve. Again, to improve the sigma of Minray, to improve the things for next meetings. Please scan this QR to all the attendants, and please give us your opinion about the meeting. Thank you.
Thank you, Ramon, so much. Bye-bye.
Bye, bye, Dr. Kader. Bye. My team, Dr. Tim Yin. Bye.
Yes, my team, and interrupting. Thank you.
Bye.
It's a bit exciting.
Yes.
Exciting presentation, but
I
I
was
like
muted,
it very
yeah.
much.
Very
I
good.
couldn't open and interrupting, and I couldn't see anything.
Thank you so much.
Thank you. I'm very glad to
Bye.
meet you. Bye.
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 Bye-bye.